This is the third lecture regarding neonatal jaundice, and today we talk about treatment modalities of indirect hyperbilirubinemia. The objective of this lecture to know types of treatments of indirect jaundice, discover the procedure, explore indications, side effect of each, and be able to make decision about time and type and time of a treatment to be started. Treatment modality include phototherapy, exchange transfusion, and in some situations metalloporphyrin and IVIG as in isoimmune hemolytic anemia. Now, phototherapy. In phototherapy, indirect bilirubin was reduced by use high-intensity light in the visible spectrum, and bilirubin absorbed light maximally in the blue range with wavelength from 420 to 470 nanometer. Also, broad spectrum white, blue, and special neurospectrum super blue light have been effective in reducing bilirubin level. Phototherapy may decrease the need of exchange transfusion but not substitute it. It acts by photoisomerization, which is conversion of toxic indirect bilirubin, which is unconjugated, to unconjugated isomer that can be excreted in the bile without need of conjugation, or it's acted by structural isomerization, which convert native bilirubin by irreversible reaction to lumirubin that is excreted in the urine and bile without conjugation. Phototherapy. The therapeutic effect of phototherapy depends on light energy emitted in the effective range of wavelength, distance between infant and light, surface area exposed of the skin, rate of hemolysis, and metabolism and excretion of bilirubin. Conventional standard phototherapy is provided at a radiance of 10 microwatt per square centimeter per nanometer with a distance from the infant about 45 cm. It is usually used for mild elevation of TSB that is not rapidly increased with no hemolysis. While intensive phototherapy, it is another advanced type of phototherapy which use a special blue light or blue-green spectrum that provide a radiance of 30 microwatt square centimeter per nanometer or more, which is usually placed 15 to 20 cm from the infant with using of fiber optic phototherapy blanket that put under the patient for maximum skin exposure. It is used when indirect bilirubin was very high, reaching maximum level for phototherapy, or rapidly increased, or there is a hemolysis. Phototherapy usually needs 6 to 12 hours to produce measurable effect. Patient on phototherapy should be necked all except eye should be patched, and the baby should be turned frequently every 2 hours for maximum exposure. A fluid intake increased by 10 to 20% due to overheating and dehydration by phototherapy, and the baby should be checked for body weight and temperature daily. Baby on phototherapy who is with hemolysis or TSP near toxic level, TSP and PCV must be checked every 4 to 8 hours, while patients with lower level do TSP and PCV every 12 to 24 hours. We should not rely on color for evaluation of patient while he is on phototherapy. Monitoring of TSP should be continued for 24 hours after stoppage of phototherapy, especially in patients with hemolytic anemia, because unexpected rise or rebound may occur. This is two types of phototherapy, and this is the light, and this is the different from light in the home, fluorescent light in the home. It is completely different. That in the home is ineffective. This is how special wavelength and irradiance. Now, what is the side effect of phototherapy? First of all, and the most important, is heating and dehydration, so we increase the fluid by 10 to 20% of maintenance during phototherapy treatment. Loose stool and diarrhea, erythematous rash, which may be macular, purpuric, chilling, eye injury by patching when we close the eye, and nasal closure from bandaging, which is very serious, may cause suffocation to the baby. So we have to close the to observe the patient closely. Crohn's baby syndrome, in which there is dark grayish brown impatient ochre in patients with direct or cholestatic jaundice. The discoloration may result from photo-induced modification of porphyrin, may last for many months. Despite the Crohn's baby syndrome, phototherapy can be continued if needed. Phototherapy was contraindicated in patients with porphyria. Now we talk to the most important modality of treatment that is very important for prevention the patient of developing kernicterus. By exchange transfusion, there is removal of bilirubin from plasma, removal of partially hemolyzed RBC, antibody-coated RBC, remove unattached antibody. These are replaced by donor RBC, which should be lacking the sensitizing antigen. In exchange transfusion, the donor blood should be fresh, less than 5 days old, irradiated whole blood. For RH incompatibility before delivery, I mean when we need it in intrauterine transfusion, we should prepare O negative blood that should be compatible with the mother. After delivery, when we need blood for exchange, the donor blood should be RH negative, whose cells are compatible with both the mother and infant. Usually use type O negative if the mother and baby ABO group was incompatible, but when the mother and infant has the same ABO, use RH negative and this ABO type, and should be cross-matched with the mother. So for example, if the mother was A negative and the baby was A positive, we use A negative. But where it is different, the mother may be O negative and the baby was B positive, we use O negative. In cases of AB incompatibility and we have to do exchange transfusion, the donor blood, use type O always, and RH negative or a group O blood and RH type of infant and should be used, and the cross match with the mother and infant. Blood volume to be exchanged is about double the blood volume of infant, so it is 2 multiplied by 85 to 100 ml multiplied by body weight. Stomach emptied before exchange to prevent aspiration. Calcium may be given during the procedure because patient may develop hypocalcemia because of anticoagulant in donor blood. Body temperature should be maintained and check vital sign. The procedure should be under strict aseptic technique, and umbilical vein is cannulated with catheter to distance not more than 7 cm in full term. Sometimes we use peripheral large vein when we cannot find the umbilical vein. Exchange transfusion carried out over 40 to 60 minutes, in which there is alternate aspiration and infusion of 20 ml each time, and sometimes 5 to 10 ml may be aspirate and infused in small baby or in sick baby with severe respiratory distress. After exchange transfusion, TSP decreased to half the pre-exchange level immediately, but it rebounded again to 40 or 50% within an hour. So we must do TSP at 4 to 8 hour interval after exchange transfusion. Some patients may need repeated exchange transfusion to prevent kernicterus, especially in cases of severe hemolysis due to RH incompatibility or in cases of irregular Najjar type 1. This is the umbilical cord, this is the artery, and this is the vein. And this is also another picture. This is the umbilical vein, and it is connected with a 3-wave valve that can turn the blood. After aspiration, we turn this needle to the worst, then again turn after that, turn the needle to the donor blood and take blood and again infuse to the patient. This is another type of 3-wave valve. Now, what is the complication of exchange transfusion? There is an acute complication which include hypoglycemia, hypocalcemia, hypoxic acidosis, transient bradycardia with or without hypocalcemia, cyanosis, vasospasm, thrombosis. Sometime during the procedure, patient may develop apnea with a bradycardia. Necrotizing enterocolitis may occur in rare situation. Thrombocytopenia, volume overload, arrhythmia, and death in best center 0.3%. Late complication due to exchange transfusion may be infection by cytomegalovirus, hepatitis, HIV, and so on. Late hypogenerative anemia, which occur 4 to 6 weeks of age because of suppression of erythropoiesis by higher hemoglobin through intrauterine or exchange transfusion. Late anemia can be distinguished from hemolytic anemia by low or absence reticulocyte count and normal bilirubin level. Treatment by iron, erythropoietin, or blood transfusion accordingly. Also, mild graft versus host reaction that may be associated with diarrhea, rash, hepatitis, and eosinophilia. Also, late complication may include portal vein thrombosis and portal hypertension due to interference with the portal vein through the umbilical catheterization. Now, what is the late complication due to hemolytic disease itself? It is either late hemolytic anemia, that persistence of hemolysis caused by circulating maternal alloantibody with high reticulocyte count, while regenerative with very low reticulocyte count. Insippisated bile syndrome, rare cholestatic jaundice, in which there is significant elevation in both direct and indirect bilirubin level in an infant with hemolytic disease. Cause is unclear. Jaundice was clear spontaneously within a few weeks or months with conservative treatment. Other treatment modality use metalloporphyrin or 10-mesoporphyrin, reduce bilirubin by inhibition of heme oxygenase. If you remember, in the metabolism, heme oxygenase will convert heme to biliverdin. So by inhibition of this heme oxygenase, there will be decrease in the bilirubin, indirect bilirubin level. So it decreases the need for phototherapy. A single dose in the first day of life may reduce the need for phototherapy. Usually it is used when the jaundice is anticipated, particularly in the cases of avion compatibility or G6PD deficiency. It may cause transient erythema when given with phototherapy. IVIG is adjunctive treatment for hyperbilirubinemia due to isoimmune hemolytic disease, ABO or RH incompatibility. Early administration of intravenous immunoglobulin may reduce the hemolysis peak serum bilirubin level and reduce the need for exchange transfusion. Also reduce the duration of phototherapy and the length of hospitalization. Now, the strategies for treatment of indirect hyperbilirubinemia in infant 35 week or more of gestation. The goal of therapy is to prevent kernicterus. Because phototherapy may require 6 to 12 hours to have measurable effect, it must be started at bilirubin level below the dose for exchange transfusion. Medical causes, when identified, should be treated that may increase the risk of kernicterus at the lower bilirubin level, like septicemia, acidosis, hypoxia, hypoglycemia, and so on. In treatment, we use a graph for guideline of intensive phototherapy and exchange transfusion, which is depending on the TSP level, age in hours and days, gestational age, and infant condition for the presence of risk factor that cause kernicterus at lower bilirubin level, which we mentioned in the lecture. Kernicterus. These risk factors include isoimmune hemolytic anemia, G6PD deficiency, asphyxia, intraventricular hemorrhage, lethargy, temperature instability, sepsis, acidosis, hypoalbuminemia, hypoglycemia, and so on. Now, this is the guideline graph for intensive phototherapy in hospitalized infant at 35 or more weeks of gestation. Now, if you see in this graph here the total serum bilirubin and here the age of the patient in hours and days, and here we can see these three curves And this curve is for infant at lower risk, in which gestational age more than 38 weeks of gestation, and the patient is well. I mean by well, there is no any risk factor that cause kernicterus at lower bilirubin level. That may include, as I mentioned, septicemia, intraventricular hemorrhage, hypoxia, acidosis, and so on. Second graph, dashed line, infant at medium risk, in which the gestational age was also more than 38 weeks of gestation but associated with risk factor, or 35 to 37 weeks of gestation, and the patient is well with no any risk factor. And third line, infant at higher risk, in which the gestational age is 35 to 37 weeks of gestation with a risk factor. So regarding the management, we choose the patient where we put her in the graph. We see the total serum bilirubin and the age of the patient with the gestational age of the patient and the general condition of the patient, if he is well or has an associated risk factor, and we put it in the graph. And these graphs is for the point for intensive phototherapy. These are intensive phototherapy level. If the TSB is not decreasing or increasing and moving to the level higher or of exchange transfusion, we must see exchange transfusion graph. Later I talk about it. And we may need exchange transfusion. And this may suggest hemolysis or sepsis. So if TSB not decreasing or increasing, so we go to the exchange transfusion graph, and this may suggest hemolysis or sepsis. Conventional phototherapy use at TSB level 2 to 3 milligram below these intensive phototherapy level. Now, this is the graph of exchange transfusion, and also here we can see the TSB level and the age of the patient, and there is a three group of the patient: infant at lower risk, infant at medium risk, infant at higher risk. So if the patient here, this is maybe an indication of phototherapy for this group. If the patient above this line, so need an exchange transfusion. All these with already, I talked previously, with already hospitalized patient that was already birthed in the hospital and stay in the hospital and develop jaundice in the hospital. For patient readmitted infant who admitted at the age of 5 days, 4 days, 7 days, or 2 days, he was coming from the home. So we put the patient on the graph to see, according to the graph mentioned previously, if he needs phototherapy, intensive phototherapy, or exchange transfusion, and treated accordingly. If the TSB level is above the exchange level in the graph at any time, or if TSB more than 25 milligram per deciliter in well and the gestational age 38 weeks of gestation, or more than 20 milligram per deciliter in sick infant, or infant less than 38 weeks of gestation, so this is an indication of exchange transfusion. But we prepare blood and cross-match that in case an exchange transfusion is necessary, and put the baby on intensive phototherapy. and repeat TSB measurement every 2 to 3 hours. And consider exchange transfusion if TSB remain above this level indicated in graph and after intensive phototherapy for 6 hours. So we repeat it every 2 to 3 hours, and if decreasing, continue on intensive phototherapy. If not decreasing, we do exchange transfusion. While patient, I talk about it previously, who is already present in the hospital, when reaching exchange transfusion level, immediately start exchange transfusion. Now, for this patient, if TSB lower, repeat within 3 to 4 hours. If TSB become 20 to 25 milligram per deciliter, repeat within 3 to 4 hours. If TSB less than 20 milligram, repeat after 4 to 6 hours. If TSB continue to fall, repeat in 8 to 12 hours. When TSB is less than 13 to 14 milligram, discontinue to phototherapy and measure TSB 24 hours after discharge to check for rebound. Bilirubin-albumin ratio can be used together in decision of treatment, but not in state of TSB level, as additional factor for determination the need for exchange. If any sign of kernicterus are noted during evaluation or treatment, as suggested anywhere in the figure or at any level of bilirubin, emergency exchange transfusion must be performed. An infant with isoimmune hemolytic disease and TSB level rising in spite of intensive phototherapy, or within 2 to 3 milligram of exchange level, we can give an intravenous immunoglobulin, IVIG, given 0.5 to 1 gram per kg over 2 hours and repeated in 12 hours if necessary. So this is the IVIG used in cases of isoimmune hemolytic anemia, I mean IBO and RH incompatibility. Always we use total bilirubin during decision of a treatment. We should not subtract direct conjugated bilirubin. But in unusual situation in which the direct bilirubin level is 50% or more of the total bilirubin, there are no good data to provide guidance for therapy, and consultation with expert gastroenterologist and hepatology is recommended. And this is a case, mostly a case of direct hyperbilirubinemia. In patients with isoimmunization, if not need immediate exchange transfusion at birth, as I mentioned in the previous lecture, treatment of birth infant with RH incompatibility, we should put him after birth immediately on phototherapy, if not need immediate transfusion. And the decision to do exchange transfusion should be based on the judgment that the infant has higher risk of rapid development of dangerous degree of anemia and hyperbilirubinemia. So if the patient does not need immediate exchange transfusion at birth, we should put him on immediately on phototherapy, and decision after that to do exchange transfusion based on the judgment that the infant has high risk of rapid development of anemia and hyperbilirubinemia. And this the presence of cord blood TSB more than 5 milligram per deciliter and hemoglobin less than 10 milligram suggests severe hemolysis, but inconsistently predict the need of exchange transfusion. Some physicians consider if it is associated with reticulocyte count more than 15%, or has history of previous baby with kernicterus, or erythroblastosis, or rapidly increasing TSB, or prematurity to be additional factors support the decision of exchange transfusion. An attempt to predict the attainment of dangerous high level of serum bilirubin depending on observing TSB more than 6 mg in the first 6 hours, or more than 10 mg in the second 6 hours, or TSB rising more than 0.5 to 1 mg per deciliter per hour can be used in the management and doing exchange transfusion, but it can be unreliable. Now, all we talk about it previously about the infant of 35 weeks of gestation or more. Now in premature infant, less than 35 weeks of gestation, we have treatment depending on birth weight and infant condition. I mean a presence of risk factor for development of kernicterus at lower bilirubin level. Here, if you see in this diagram, birth weight of the infant less than 1 kilo, 1000 gram to 1250 gram and more. And here the uncomplicated and complicated. Here uncomplicated mean have no other problems, septicemia, hypoxia, acidosis. Complicated if it is associated with these factors, which is called the risk factor that led to development of kernicterus at lower bilirubin level. I mentioned it multiple times, is the septicemia, hypoxia, acidosis, and so on. So these patients with these risk factor and those patients without risk factor, and these are the level of exchange transfusion. Phototherapy usually started at 50 to 70% of this maximum level. So started at 50 to 70% of this level. If value exceeds this level of phototherapy is unsuccessful in reducing maximum bilirubin level or sign of kernicterus evident, exchange transfusion level. So these are the exchange level, and 50 to 70% of this level we start phototherapy. Risk factor, as I mentioned previously, asphyxia, acidosis, hypoxia, hypoalbuminemia, sepsis, meningitis, and so on. This is another chart for a premature infant of 35 weeks of gestation and less. الأرقام اللي موجودة بهذا الجدول قبله for premature infant ومطلوبة للحفظ. In this new chart, we depend on gestational age and infant condition for presence of risk factor. I mentioned it previously multiple times, and you can see here the phototherapy level and here the exchange level. With this phototherapy level, this yellow figure indicate if the patient have risk factor, here the patient with no risk factor, here also an exchange level, this figure with patient and patient with risk factor, and here without risk factor. Thank you very much.